Hi, everybody. My name is Paul Lin. I'm from Taiwan. It will be my great pleasure to share some of the information that I have with Guide. Today, my topic is predictable soft tissue grafting for aesthetics in thin periodontium. I like to divide it into 4 sessions. First, an introduction, then the technique principles, then I'll share with you some cases, and then short concluding remarks. First of all, let's start with the introduction. What does predictable mean? Ideal consistency is unrealistic in clinical standpoint. That means 100% of the time it's predictable, 10 out of 10. But in non-parametric testing, with minimal requirement, there has to be 3 out of 4, which means 75% of the time means predictable. But in clinical, what is achievable is clinical reproducibility is 80%, which means 4 out of 5 is predictable. But some clinical cases is not predictable, but it's possible. I have to tell you that, for example, like this cases, there is some immediate implant placement following extraction with a vertical augmentation as well as soft tissue coverage. It's going to be very difficult to achieve in one setting, but it's possible. Some people do it. I can do it in some cases, but I don't say that it's predictable. Now, in order to do a root coverage for Class 1 and Class 2 Miller classification, predictable in these cases will be then to perform an envelope flap on tooth number 24 or envelope flap on tooth number 6 and 11. An envelope flap are all maxillary anteriors that altogether connected will be called a tunnel procedure. Now, in thin periodontium, in Asian population, 85% of the time, we can confront the patient with thinner gingiva, both buccally as well as palatally. Now, those populations also come with thinner alveolar bone, which likely to find fenestration and dehiscence. And also taller papilla, which means 50% of the length of the crown consists of the length of the papilla. Now, in thick periodontium, which unlikely the cases we confront in Asian population, like this, we have 2 central incisors that was traumatized and need to be removed and be placed with implant. And it can be stabilized for over 2 to 3 years without any tissue changes. But in thin periodontium, here we can depict that there's some thinner buccal tissue and thinner palatal tissue that could easily occur in the population that we're facing. Now, this is a case of thin periodontium which was treated in 1998. At that time, after flap elevation, you can see a severe bone destruction. We were able to achieve in regeneration in 6 weeks during the time of the membrane removal. And 5 years later, there's additional soft tissue recession following due to the thickness of the tissue is too thin. And we have to perform a soft tissue grafting to augment the thickness, and then it was stabilized for another 5 years until the teeth was fractured and replaced with a new implant. Now, during the implant placement, there's no longer need for soft tissue augmentation because there's previous tissue procedure that was rendered. In this instance, the patient with thin periodontium, which require extraction and immediate implant placement following extraction, 3 years later, there's not much tissue recession. However, in 5 years, there's continuous tissue thinning. As you can see here, there's some recession occur. You can see the zirconia abutment that's showing through with metal that is showing through the soft tissue. Now, in this instance of the thin periodontium, during implant placement, we always wanted to have a soft tissue augmentation at the same time in order to achieve a long-term stability of the implant and the tissue. What about soft tissue grafting for aesthetics? Now, soft tissue grafting for aesthetics enhancement, for example, like this patient has a periodontal need, which means around natural teeth, there is some crown lengthening needed for this asymmetry and root coverage needed for this recession and papilla augmentation needed for this blunted papilla. Now, these all kinds of aesthetic enhancement can be done on the natural teeth. And there's also a need for periodontal situation, which means around edentulous area, there is a socket preservation needed for this tooth that's going to be removed, or a ridge augmentation needed for the ridge that already resorbed severely. Now, there's all kinds of ridge augmentation can be performed to augment as well as to preserve the ridges that are going to be resorbed. As far as peri-implant site, for this socket area, we can perform ridge preservation, and the site with existing resorption, we can provide site preparation. And there's the situation where site preparation as well as immediate implant placement can be performed to preserve the ridge in order to achieve the soft tissue grafting enhancement. Now, crown lengthening, root coverage, papilla augmentation, ridge preservation, and ridge augmentation is that procedure that we normally do to enhance the soft tissue. As far as clinical crown lengthening is not meant for grafting procedure, however, the crown lengthening procedure can be performed by gingivectomy as well as osseous surgery. Oftentimes, it was used in combination with root coverages or ridge augmentation because it can help to level the soft tissue in a way that is symmetric or following the gingival alignment. For root coverages and papilla augmentation, as well as papilla preservation, is a time when we utilize soft tissue grafting predictably. And socket and ridge preservation can be performed with connective tissue grafting, but this is not a procedure I normally do right now because I think the socket seal procedure in Asian population, due to the thinning of the palatal tissue, is not adequate to perform a good seal. So connective tissue graft is a substitute, but for now on, because of the provisionalization, there's really no need for connective tissue grafting at the same time. For site preparation and ridge augmentation, normally we will utilize soft tissue for ridge augmentation in order to achieve a natural look. In this instance, for example, this patient was augmented with soft tissue only, not just for number 7 as well as for number. Take this patient, for example, he would like to improve his aesthetics. When we take a closer look, we notice that there is a problem with the incisal edges as well as the soft tissue alignment. What we can do is try to improve the alignment of the tooth first to determine the incisal edges. Then after that, we provide the root coverage as well as ridge augmentation to better off the soft tissue profile. And then put it back in the patient's mouth. With smile, the patient can change his smile and the smile can be enhanced due to certain soft tissue grafting procedure in addition to the orthodontic treatment. Take another example, this young lady who requested a new restoration made to solve the problem of the artificial gingiva. She hoped that all the artificial gingiva can be replaced with natural gum. With some soft tissue grafting, twice of the time, utilizing pouch technique, we were able to regenerate the soft tissue covering the implant as well as edentulous area with two papilla in between 9 and 10 and 8 and 9 and some root coverage on number 10, that this particular soft tissue can be enhanced to better off her look. Later on, I'll demonstrate these cases to see what was done. So next is techniques principles. I like to share with you two different techniques. Now first is the connective tissue graft, CTG. Second is a flap, is a particulated flap. The soft tissue grafting for aesthetics, the graft that we were using would be a subepithelial connective tissue graft, likely now, compared to used to be a favorite called free autogenous gingival graft, because of the color blending is much better now in subepithelial connective tissue graft. For Miller class 1 and 2, we can anticipate a 100% root coverages. Whether or not it's exceeding mucogingival junction is not a matter. For root coverage of class 3 classification, there are likely a possibility to get 100%, but oftentimes because of the papilla did not fill in, we weren't able to achieve 100% root coverage. Then we will calculate from the level of the adjacent papilla to the gingival margin to expect at least half of the amount of the vertical height can be covered. Now there are grafting principles for recipient side. First is to minimize the use of verticals. The second is to perform a partial thickness of flap, elevation, and leaving the intact periosteum. Third is to access through sulcus only in natural teeth for class 1 or class 2. The fourth is the access through the pouch in class 3 for edentulous area or for implant. Let's take a look at the first one, minimize the use of verticals. In these 6 maxillary anteriors, we have performed 5 different procedures to achieve in root coverage. First of all, number 9 with semilunar, number 10 with chorally positioned flap with 2 verticals, number 11 with double papilla, 6 and 7 with tunnel procedures, number 8 with envelope procedures. And that was achieved 3 years later. Now, for number 11 and for number 6 and 7, we perform a tunnel procedure without making any verticals, and we can allow the graft to expose due to no verticals. We can allow the graft tissue to expose on the denuded root surfaces and still can achieve 100% root coverages. As far as partial thickness elevation or leaving the intact periosteum and access through sulcus only in natural teeth, we can take a look through these instances. Now, this is a procedure performed by tunnel. All we need to do is try to connect from 2 envelope without severing the papilla in between 10 and 11, and we can place a graft in there and achieved in 100% root coverages. Access through pouch in class 3 or edentulous area or implant. In these instances, I would like to try making incision from the side instead of from the sulcus. Well, that's how we call it a pouch procedures. Now this is good for root coverage of class 3 Milam classification as well as for implant root coverage and augmentation. Root coverage can be obtained by lateral position flap in conjunction with connective tissue graft as well. With only one vertical, we can laterally move the covering flap for the connective tissue to achieve not just bone augmentation as well as root coverages. This is another case showing that root coverage can be obtained by coronally positioned flap and connective tissue graft with two verticals. But cases like this demand technical sufficiency a lot more than without flap elevation. Grafting principle for donor side. First of all, I like to recommend to harvest tissue from retromolar side for reliable thick tissue. And then during the side preparation, we have to elevate the very thin covering flap to obtain graft with maximum thickness from the palate, or leaving the periosteum intact to provide good blood supply for donor tissue covering the flap. Let's look at the first example. If we can obtain the graft firstly from retromolar area, that's the thickest tissue you can harvest. Sometime when patients are lacking second molar or third molar, you can easily access this area to obtain the graft tissue, or to acquire the tissue from inside of the wedge or from internal flap to obtain certain thickness of the tissue. This is how we go by using number 12 blade to remove the tissue from retromolar distal wedge. And it can be utilized for the donor tissue for thicker grafting. Now, second of all, we can elevate very thin covering flap. What do I mean by that? Is by making the incision, we can look from the cross-section here. This particular incision has to be very, very slowly and careful in order to make it very thin. Thinning this tissue allowed us to obtain this is third cut, and leaving the periosteum intact. Now we can obtain a very thick tissue at this moment. The reason leaving the periosteum intact is to provide a good blood supply for the covering flap, as well as providing the future memory to regain its thickness in time for maybe the future procedures. This is the side that we're leaving the periosteum intact, and that's the side without the periosteum. In 3 months after the graft harvest, there's still some concavities remains. Another 2 cut to the side, the graft can now be removed in one piece. The thickness of the tissue for thin periodontium is very important for future use. Generally speaking, we would like to trim the harvest graft for future use. Make sure that you obtain at least 1.5 millimeter thickness for root coverage or ridge augmentation. Another important issue is trying to secure the donor side with suture. After graft harvesting, This kind of suture is no longer used because of the necrosis occurred of the covering flap, easily due to suspensory suture not providing enough blood supply to the covering flap. So, under the suggestion of Dr. Sasha Jovanovic, this is the better way of securing the covering flap by making the horizontal incision and coming through the periosteum of the interdental area, making a vertical matrix and a horizontal combination matrix to secure this particular covering flap. So then this is after suture. 1 week later, you can see all the covering flap with underlining periosteum providing the good intimate blood supply. All tissue can be survived, so the patient does not suffer from any type of hemostasis problem or painful situation. Another area for soft tissue grafting is papilla preservation and augmentation. Now, in Tarno's famous study, which is published in 1992, he indicated that in 1/3 of the anterior teeth, he found that there is a distance between contact point and crest of bone of 5 millimeters to be able to predict the papilla present almost 98% of the time. Now, for a distance of 6 millimeters, there's only half of the chance that papilla will be present, and 7 millimeters, a quarter of the chance. The same study was copied in Chinese population, where 200 of the size all study under the anterior region. The contact point to crest of bone was just about the same that was found by Tarno. However, it was a little less in 7 millimeter papilla height. There's less than a quarter. So comparing these two studies, that we can predict there's a 5 millimeter rule for papilla to be present between the contact point and the crest of bone. However, in a clinical situation, when we elevate the flap in a thin periodontium, there's always a chance for future papilla loss. Given the fact that the bone is regenerated, we still need to place a tissue in order to preserve the height of the papilla to a 5 millimeter rule, or maybe even to augment the tissue in thicker way. However, in order to achieve a higher or taller papillar height, the study by Salama's brother, which looked at interproximal height of bone, would give you an idea where there's a existence of the pontic and the tooth, or the pontic with the implant, or pontic to the pontic relationship, given the best look and height of the vertical gingival dimensions. The best will be then the tooth to pontic relationship, then the pontic to pontic relationship. In this instance, we have this number 9 and 10, which will be removed. After that, the ridge augmentation was performed primarily by soft tissue grafting. As you can see here, papilla was reformed, and this is 1 year and a half that you can see from the pontic to natural teeth. There's about 6.5 millimeter height. The pontic to pontic tissue height is about 6 millimeter. A ridge augmentation is oftentimes can be achieved by soft tissue grafting. Now, for pontic, during the crown lengthening procedures, we can place a graft underneath the flap, or In this instance, we reach for number 7, a graft from retromolar area, and number 10 from palate. Now we look at the second technique, the flap, which is called the peticulated flap. It's good for ridge augmentation. Primarily, the technique we're using is a modified roll technique originated from Abrams in 1980. It was meant to correct class 1 mild to moderate defect or to increase the buccal tissue thickness. Now, the only requirement is that patient has to have a thick palatal tissue, which means the tissue has to be thicker than 3 millimeters. Now, in this case, we utilize roll technique to increase the buccal thickness for this edentulous area on number 10. And this implant on number 11, during the second stage, we were able to roll the tissue from the palate to augment the thickness on the buccal side, and that vertical cut can be diminishing over a year or two. Generally speaking, we will make an H-shaped incision with a horizontal incision to the palatal aspect of the shoulder of the implant. And then we will perform an elevation, very thin palatal flap, and then elevate from beneath the tissue that connected with the buccal flap. Then insert the elevated palatal tissue into the buccal pouch that was made and is secured with overlaying suture. This is an implant that was, following extraction, was placed and covered with membrane, but after 3 months later, before the exposure of the implant, as you notice, there's a concavity slightly occur on the facial aspect. So we then can perform a roll technique to augment the facial concavity. This case was also done by roll technique during the final phase of the provisional. The patient complained of concavity occurred, so we have to remove the abutment and then still perform the roll technique to cover this hole as well as augmenting the buccal concavity as well. In the end, we can satisfy the patient with a natural looking appearance. Now this is premolar. During the second stage, concavity occurred. We then provide the roll technique procedure to augment this much tissue moving from palate to the buccal. This is the procedure that was illustrated with this flap as thin as possible elevated from palate. Then we can move the palatal tissue in enough thickness, hopefully at least 2 millimeters, and leaving the periosteum intact. We can roll this particular tissue from palate to the buccal. Then we secure with a matrix suture and into a pouch, and then we replace with abutment or healing abutment. And before the stitches was cut, we then double tie to the palatal surface, making sure the elevated flap from palate can be secured tightly against the periosteum underneath there to provide a good blood supply so that this particular tissue can have good protection for the lingual surface of the implant. And at the same time, the buccal tissue was then augmented. Now we look at some case reports. This particular patient has actually 6 teeth in a row that has recession, which causing unpleasant look. Now, we're trying to cover these 3 teeth at the same time by tunnel procedure. First of all, we will make the root clean by scaling a root planing thoroughly to a smooth and hard surface. Then we make incision, sulcular incision, to provide a initial entry. Then we start with mini blade to then make a pouch for each individual teeth. Now, the access through this area is called envelope access, and between two envelopes, we then connect the papilla in one layer, make sure that we can elevate altogether the buccal tissue at the same time, so that was in the same level. We then harvest the graft and secure the graft with a remote incision connecting with matrix suturing and pull it back into position. And secure with the matrix suture on both sides. As long as this tissue is tight, adhered to the root tight enough, then we can then leave it without any protection, and it will turn into the patient's tissue with increase in keratinized tissue at the same time. Number 9 to 11 was performed with the same technique, only with a thinner tissue. For this Miller classification 3, we generally will not approach by an envelope. We call this as a pouch approach, meaning that we make an entry not through sulcus, instead through the side of the recession area. Generally speaking, we would like to leave at least a 3 millimeter away to make the vertical incision, and then we start our needle through this recession area and then connect it to the vertical cut to pull this graft tissue along with the passage of the elevation, then secure with matrix suture, and then close the vertical incision. And this is 1 year later. Another case is where we'll look at number 10, where you can see that there's some pocketing on the distal aspect. This patient had the experience of receiving guided tissue regeneration, which at the end there is some more tissue recession occurred, not just on number 6 and number 8, but also on the teeth that was regenerated on number 7, as well as the papilla. Now, the patient was afraid that the future surgery work on number 10 and 11 would occur the same phenomenon, so then she was agreed upon having a regeneration procedure not using guided tissue barrier, but rather using Emdogain as well as connective tissue at the same time, to trying to cover the root as well as to preserve the papilla. Now this we perform with papilla preservation technique, and we make only one vertical cut to the distal of number 11, and we elevate it to the medial number 10, and we were able to achieve in obtaining a connective tissue graft to cover 2 denuded root. At the same time, we was able to place Emdogain and bone graft, DFDBA, before the coverage of the soft tissue. Now the flap was secured. For the area that we make a vertical incision, we will always try to cover the graft tissue completely. For the area we did not make any verticals, we can leave some grafted tissue exposed, and then it will be covered altogether by the future tissue migration. And 3 weeks later, during suture removal, there may be some recession of interdental tissue. However, given time, this tissue will migrate back due to the 5 millimeter rule. Now another area, number 7, was covered by a tissue harvest from retromolar area to gain root coverages. Due to the thinning of these tissue, very difficult to make a pouch or access through sulcus. We have to make 2 vertical cut and coronal position the flap in order to cover the grafted tissue completely. Now this is the case that we start with scaling and root planing of number 6 to number 8, and then this is what happened after the scaling and root planing, and we started to work on number 10 and 11 with root coverage and papilla preservation, and then this particular papilla started to regrow back to its original form, and we then perform a root coverage on number 7. And the provisional was modified to a final look of the marginal placement. This is another case that was performed pretty much the same technique, utilizing 1 vertical to the distal aspect of the site and leaving the medial aspect intact. We were able to perform apical surgery to remove the darkened apical area, as well as amnion and bone graft and connective tissue graft to cover the denuded root surfaces. And this particular graft was secured with a remote connection by matrix suture, and this is healing 3 years later. And the pocket from the buccal aspect of number 10 started with 7, now was closed to number to 2 millimeter. Another case will be the implant placement of number 8 following bone augmentation, as well as implant placement 3 months before. During the exposure, as you can see, there's about a concavity of probably around 3 to 4 millimeter that need to be augmented. Now, the soft tissue support then will come into play by the grafting from connective tissue. By making papilla preservation cut with 2 vertical, preserving the interdental papilla, making the vertical not exceeding the mucogingival junction, and elevated flap partial thickness, and we remove the covering tissue on top of the implant to the side to augment a little bit of the papilla. Then this back action chisel is good for removing all the tissue that covering the implant shoulder. With detailed cleaning using Q-Rad, that's a younger good 7/8. Then we remove the covering cap and replace with healing abutment. Now what we need is make a pouch underneath the vertical, providing room for future grafting to be placed. Open knife was used to make the pouch. Measurement was taken to harvest to then determine the size of the tissue that to be harvested. Now we make a first cut to the periodontium, and then we start to making very slowly the second cut to thin this covering flap. For thin periodontium, the donor tissue from the palate can be also very thin. We have to make every endeavor to try to preserve the thickness of the palate by leaving this palate flap thin enough. So we will try to harvest vertically about 7 to 8 millimeter, horizontally 12 millimeter, so we can place to the buccal aspect of tooth number 8 to pump up the buccal concavity. This is to make the apical cut. Care was taken not to exceed where the blood vessel and the nerve is. Generally speaking, it will be around 19 millimeter. Internally, we elevate the flap, the graft, by knife instead of using periosteum elevator, because we try to leave the periosteum intact. Now it's very important that we cover the flap instantly using suture. We're using 4-0 silk with horizontal matrix and vertical matrix coming through the periosteum. You can see the covering flap is tightly secure against the underlying periosteum. Then we transfer the harvested graft to the donor site by 2 matrix suture. And 2 sling suture. And then secure the covering flap with 2 interrupted to make sure that all the donor tissue was covered, because there's 2 vertical was made. Then we secure the side with 2 vertical. So this is the slide of the video. You can see that we performed a partial thickness elevation during the second stage, and the healing abutment was placed, and the flap and the graft was secured buccally, and the donor, the recipient side was closed completely to cover the graft. This is about 3 weeks, and abutment was installed in about 6 weeks. The zirconia abutment was placed, and there's a final prosthesis was made. In other cases was the roll technique utilized on the number 7, where in this cases we can elevate the donor palate to then augment the buccal concavity is about 2 to 3 millimeters. H-shaped incision was made with horizontal, hopefully located at the lingual aspect of the implant shoulder. Then we make partial thickness of this covering flap as thin as possible, and we use knife and then back action chisel to elevate the donor tissue, and to try to roll this particular tissue connected with the buccal flap with partial thickness elevation using knife primarily. Then the covering screw was removed, healing abutment placed, and the pouch was expanded, and the rolled flap was secured the same manner, pretty much the same like connective tissue. In this case, because the number 6 was distally and apically rotated and apically positioned, we have to elevate the papilla in order to augment the papilla in between 6 and 7. So there's preservation only was performed on the major aspect of number 7. Now, due to the concavity occurred on the lingual aspect of number 10, we were able to harvest connective tissue from retromolar area and place it underneath this lingual flap. And we can secure with the double tie in order to allow the covering flap to tightly secure against the periosteum underneath there. This is during the flap, the graft harvest before it was rolled, and was rolled to the buccal aspect of it and then secure with double tie technique. Now, making one incision before cutting it, we can come up to the lingual aspect and then tie it at the second time. So there's a double tie here. This is during the healing, and the implant was then supported with the abutment, and there was final restoration. Another case would be to augment following abutment insertion and provisional placement. There is still a concavity. The patient complained about the darkened shaded area of number 6. As you can see, there's some marginal recession occurred. We were able to perform a pouch making a vertical distal to this number 11, and we harvested a very thick donor tissue that was able to insert inside, and this is 3 months later, and this is 1 year later. Now, the procedure was a little different from on the natural teeth, because on the implant, we hardly ever make this cut from sulcula. We make primarily a vertical cut distal to the area that need to be covered, and then pouch this area and receive the graft in place and then secure with another suture. This is before the implant placement, this is after implant placement, and this is after the grafting to correct the depression on the buccal aspect of this tooth. Another instance will be the same procedure was utilized on this particular patient, where she complained this particular implant was placed too high up and too buccally, and giving her look of depression here and a darkened area. We were able to remove the crown margin, exposing some implant color, and graft was inserted from the distal aspect of the pouch and is secured to the apical aspect of this number 11. Now, 1 week later, the graft was then migrated down to cover the exposed root surface. Now, the appearance of this particular implant was giving a pleasant, harmonious look after the surgery. The same situation with the same technique can be utilized on patient after implant placement for more than 5 years. A continuous buccal concavity and marginal recession occur on this patient can be covered without removing the crown and abutment, just by pouching to the distal aspect of number 10. We were able to augment this buccal tissue and shortening the crown with the apical, with the coronal movement of the grafted tissue. Now, there's another case where we were able to utilize soft tissue grafting to augment not just buccal aspect of the implant and dentures area, as well as the interdental space of these two teeth, and number 9 and 10, and number 8 and 9. The patient was complaining of the appearance of the margin of the plastic provisional, that during her smile she can visualize it, and she would like to have it changed to a better looking. Now we noticed there's a problem of high smile line, and demand was high to try to replace this particular plastic tissue into a soft tissue. And the patient has multiple gingival recession and multiple papilla loss, and poor implant positioning, which was done at the age of 15 when she had a trauma at that time. And there is some restorative limitation due to the inability to remove this implant and change the implant system. So we then harvest a graft from retromolar area and from palate as well, and we insert by making a pouch from the apical coronal position, and try to wrap this soft tissue around the buccal aspect and the occlusal aspect and the lingual aspect, and release this tissue and secure at the same time to try to cover all the donor tissue. And this is about 3 months later, making another incision to the side to augment this area to hopefully achieve in coverage of number 10 and augment the edentulous area. Bilateral pouch. So then this is before, and this is 2 months later, and this is 6 months later where the second surgery was performed. This is about 6 months later, and 1 year later, patient received a permanent restoration. Now, in concluding, for soft tissue defect, it was suggested by ITI consensus report as a aesthetic risk assessment, a high risk population. So regardless whether you have a problem with the natural teeth or teeth that is going to be removed biomechanically on these 6 lateral incisors, we can all try to achieve an aesthetic outcome by keeping the natural teeth with bone augmentation as well as soft tissue augmentation, or the soft tissue augmentation for edentulous area, or the soft tissue and hard tissue augmentation for implant placement. And regardless what was inside of the soft tissue, whether it's a natural root or edentulous area or implant service, we can always try to accomplish a natural looking aesthetics by maybe using soft tissue grafting in all these teeth. For aging population, this is the case performed on the patient at the age of 70. We can still achieve a good aesthetic result, providing a future better looking restoration with good soft tissue root coverage and ridge augmentation at the same time, in order to achieve ideal convex and concavity of the natural looking tissue. Now, there's only one limiting factors is the interdental papilla, where we cannot achieve in any augmentation of the interdental papilla, where there may be a consideration of a artificial fixed prosthesis can be done. Now, the principle utilized on the soft tissue grafting on the implant and natural teeth may be similar. However, the thickness of the soft tissue that was obtained for implant can somehow contribute to the vertical level to increase the height and change the margin of the implant surface a little bit due to the concept of the width to height ratio, a 1.5 ratio, different from the ratio of the height to width, a 1.5 on natural teeth. So aesthetic is a state of peace of mind when you perform it. Hopefully it's under your experience and precise execution. It matters only when you value, because if the patient doesn't know how to request, you can then provide what you think is the best for the patient, and in some instances for the patient with thin periodontium, you can achieve in predictable root coverage as well ridge augmentation to provide a better aesthetics. And the less procedure is performed, the more the patient can gain from your procedure. I thank you very much for your attention. Thank you.
For more education programs, visit the Guide Institute at www.guidedental.com.